Okay, so let's talk about junctional rhythms, and that means basically they're coming from the junction, and that means that they come below the SA node. So typically, we do not see a normal P wave. P wave may be biphasic. We may see a P wave that is inverted in a lead where it should not be inverted. It should be giving us a positive deflection. And when it's biphasic, it might look like, I don't know, this thing's not going to let me write, but let me maybe draw. It'll look like this, inverted, and then you'll have your QRS here, or you may have, which is like a biphasic, or you may be like, just looking at something like that with your QRS and your T here. So typically we say that's really not a P wave in reality, so we don't consider it to be a P wave. But your junctional rhythms are you're going to either have some really harmless PJCs, just like you have your PACs and your uh, unifocal PVCs that are non-frequent, or your PJCs. But when I say they're non-harmful, any of these little beats like a PJC, a PAC, or a PVC, if they start to become more frequent, you really need to put your thinking cap on and figure out what's going on, because they can lead to much bigger arrhythmias. Okay. So, junctional rhythms, typically we have just PJCs, which are not really a rhythm, but it's just what we call a funky little beat that happens that you need to be aware of. But we have a junctional Brady, a junctional rhythm, accelerated junctional, or a junctional tach. Okay. So if you tell me, oh, Miss Pizzotti, come on, I'm not memorizing all that. I agree. So I really just think that we needed to kind of run through this because, in the book, it does, talk about junctional and the different rhythms. But if you can just tell me it is a junctional rhythm, then I am fine with that, identifying that junctional rhythm. Okay. Okay. And by junction, I'll show you. All right. So let's go down here to the next one. Oh, Um, I don't know why it's not moving, but let me see if I can get it to move. There we go. Okay, so let's erase this draw on here, and let's look at this. This is what if you were to just look at this and you don't go through your 5 steps, you would just tell me this is sinus Brady. But you need to start your 5 steps every time. So we're looking at it, and we say the first thing we look at the rate. So we know it's 1, 2, 3, 4. We know it's a rate of 40. We know this is a some type of slow rhythm. Okay, then the next thing we look at is the morphology of the P's. Well, I'll be darned, we don't have any P's. Okay, so I'm going to put that in my thinking cap. I have no P's. And I also do not, everything looks, like it is equidistant, especially the QRS. The QRS is not wide. You have a T wave for every QRS, but you're just missing P's. Okay. This is my first sign. If my leads are right, if I know I'm in a lead where, I should absolutely see P waves and my patient's leads are on right. Yeah, then I'm thinking along the lines of junctional. And I would call this, because it is in the 40s, it would be, a slow junctional rhythm. I'm happy with just a junctional rhythm. Um, you know, if you to identify this, as long as you know if there's no P waves, none, that's most likely a junctional rhythm. So, how do we treat it? What's the treatment here? Okay, so what? But first of all, why do we get it? We see this a lot in what is called a sick sinus syndrome. You'll hear that, used sometimes, sick sinus syndrome. We'll see it including drug induced, which is, DIG will do. You can see it in ischemia of the AV node, especially because, it is coming from below the AV node, or from the AV node, or below the AV node, I'm sorry. And so, and especially with, and the reason why we bring up junctional is because your patient, sometimes this is the first sign for an acute inferior infarction. So and and this is involving the posterior descending artery, and so that's what affects that AV node of the artery. So very important to know, if your patient just starts to go into a junctional rhythm, this is something that you need to hook up a 12 lead and, call your doctor and say, what do you want to do? And the doctor has, usually cardiology is smart enough to know, well, this is harmless or it's not. But, they'll tell you to get a 12 lead, make sure, especially if it's something that comes up. And, you look at the drugs that cause it. And what's the treatment? Okay, is it stable or is it unstable? Most rates 60 to 100 are not going to be symptomatic. They're not. But if you're having an MI, they will, right? That's just common sense. But if they're not having an MI, they're not symptomatic, you're just going to kind of watch and wait with this. An unstable junctional bradycardia will be treated just like junctional, like a bradycardia, because it's unstable. It's a bradycardia. We're going to give that atropine, and we're going to wait for a pacemaker, like most bradycardias. If the bradycardia is symptomatic enough, you're going to give some atropine, and you're going to hook them to a pacemaker, right? And most likely it'd be transcutaneous at first while you're waiting, somebody come in and transvenous, um, you know, whatever the doctor chooses to do. So, if you have an unstable junctional tachycardia, if it's fast though, the atropine will not help. Okay, so you got to treat the underlying cause, and most of the time it's a fever, anxiety, pain, hypovolemia, ditch toxicity. So if you have these high heart rates, you're looking at, you may have to cardiovert them, versus atropine in a pacemaker when it's bradycardia. Okay. So this is kind of a harmless red. Let me stretch this out, make this bigger a bit so you can see. You had PACs, and I like, this is the easiest way to remember a PJC is that, all right, we're looking at this rhythm. When we look at the underlying rhythm, we got 1, 2, 3, 4, 5, 6. That's a sinus rhythm. We look at the P waves and everything look about the same until we get here. Okay. But let's move on. Here we got PAs all look the same. If we were to look at these beats, they all look, about equidistant. We might have a depressed ST segment, but I think it's got to be a little bigger than that. It might be borderline, but we'll look at that. It's better to look at a 12 lead for a depressed ST segment. I mean, if you think you see a depressed ST, then you better, get a 12 lead. But this is, right now you're looking at, you got T waves, your QRSs, except for maybe this one because it's not, a P doesn't precede it. So we got everything normal except for this little beat. Now remember when we had PACs, it was an early beat with a P wave. If you have an early beat with no P wave, then that's a PJC. Okay? That's the way you tell them apart. You got this early beat. It's not wide and bizarre like a PVC or premature ventricular contraction. This is a premature junctional contraction. It's coming from the junction, so it's below the at or below the AV node. So you're not going to see a P wave, and you are going to just have this early beat, this early ventricular contraction. But it's not wide and bizarre, so it's coming from above the ventricle, but around the AV node. So it's just an early beat. But like I said, you need to watch them because if they start to occur more often, you probably got some type of issue going on there. And so your treatment is typically, this is caused by nicotine or caffeine. And your treatment, these are usually harmless, no treatment except avoidance of those things. And absolutely, absolutely, if they start to occur more often, it's something that you need to let your physician know about. Okay. So we'll go into idioventricular rhythms because we got, a little more time here. Idioventricular rhythms are, they either call them idioventricular or accelerated idioventricular. And sometimes you'll hear these called agonal, an agonal. Sometimes you hear them called agonal, Agonal, and sometimes, or a dying heart, you know, rhythm. But idioventricular rhythms don't necessarily mean that the heart is dying. I mean, it just is getting very weak. So we often see these, and people will come in these rhythms, and they're kind of hard to identify, but they they typically, don't, you would call this probably junctional because it doesn't have any P waves, but you have this wide, bizarre, QRS, but it's not a PVC, and if you count it out, it's too slow to be VTAC if you want to argue with me that these are PVCs. But this is what this is called an idioventricular rhythm. It's too slow to be VTAC. And ideally, what it is that you got, this, um, you know, heart that's not working optimally. And they're not that hard to pick out when you look at that, you know. You're looking at usually a wide QRS and it's slow. And the treatment, these are usually you know, treated with beta blockers, or they hold the drug that's caused this, um, so the treatment is, if it's pulseless, you're going to treat it just like PEA, and we're going to look at PEA in a minute. Um, Even if there's a pulse, you're going to need a pacemaker. Because they're slow, so you're going to treat it like a bradycardia, right? But atropine is not going to work here. Okay. Unless you can't get a pacemaker, atropine will be given just like a bradycardia. So, but if it gets pulseless, you got to treat it like a PEA, but you cannot cardiovert this. So it's treatment. If it's pulseless, treat it like PEA. If it's you're able to give atropine, treat it like this bradycardia. If it's stable, and we try to get a pacemaker if at all possible. But some people will just be fine and be stable, with an idioventricular rhythm. But if they, have symptoms, then that's absolutely, you're going to have to treat it. And if they're have symptoms and they're awake and alert, but have symptoms, you're looking at, possibly giving them some atropine, planning a pacemaker. But man, if they're like this, and they want you to treat it like PEA, and we're going to come down to PEA. PEA can look like a sinus rhythm, y'all. It really can, or it can look like anything else that might have a pulse. Okay. But what it is we call it pulseless electrical activity. Okay. And so pulseless electrical activity means that you may see this on the monitor, and usually it's slower than this. I'm sorry about this strip, but it can be anything, and that usually has a pulse, like a bradycardia, idioventricular rhythm, something like that. It's usually slow, and we will try to check a pulse, and there will be none. Okay, but you still have electrical activity up on the monitor that looks like they should have a pulse. So we treat it. It's clinically associated with the H's and the T's, and I forgot to write that down there, but also with advanced cardiac disease, severe cardiac conduction, end stage heart failure. But what you have is the presence of electrical activity of the heart, as evidenced by an EKG rhythm, but not VFib or VTAC. It doesn't look like VFib or VTAC. It will often look like a bradycardia or an idioventricular rhythm. So, your H's and T's are there, and your treatment. We got to get them CPR. We got to get them intubated, and we give epinephrine. And atropine is used if the rate's slow. Um, we want to speed it up. So basically, this patient has no, muscle contraction. It's sending the electrical signal, but it's getting no muscle contraction at all. So that's diagnosed by not being able to palpate a pulse, and you look like you got like some type of bradycardia, or a sinus sinus bradycardia or idioventricular rhythm. I don't know why I put that there. And you don't have a pulse, so you're going to have to treat it with, of course, you have to get the CPR started, right? You want to get them intubated. You want to give them some epinephrine. You want to give them atropine if the rate is slow, which most likely is going to be slow. So just consider your treatment for PEA, CPR followed by epi and atropine. So it's going to be CPR first, right? So you're going to do CPR. Then, somebody is going to give them epi, right? and then 1 milligram IV, and then atropine. And user use 0.5 to 1 milligram, 0.5 IV. Epinatropine, CPR. Okay. And what else? And then, once you get that done, you want to try to pace them. That's probably the best, because this is going to be a really slow rhythm. And like I said, that strip I put up there ain't right. I should have put a slow one, like an idioventricular or bradycardic. Um, but epinephrine and atropine, get them paced. Transcutaneous pacing. So put the pacing pads on them. So anything slow you want to try and pace, right? Okay, so let me clear all. Okay. So when we get back, we're going to talk about AV blocks, or heart blocks, and that will be the end of the series, I believe. And I think there's a little bit more on pacemakers, but we talked a lot about pacemakers already, but we'll talk more intently about what a pacemaker is, and how would you troubleshoot it. You don't really need to know this for NCLEX, but just be aware that, sometimes we, as RNs, when if you move past LPN to RN, you're in control of the pacemaker, and it can be troubleshooted. So we'll talk about AV heart blocks, first degree, second degree, type 1 and type 2, and third degree heart block. These are not in your book, but it's also very, very good to know, and you'll see why. All right, bye.